So this is a young woman who comes in with abdominal pain and diarrhea, and I'm going to run through the CT that she received for the same. And I'm going to withhold one part of the history right now, so I can ask you some differentials. As you can see, as I'm scrolling through, the liver looks okay. There is ascites. There's some focal thickening at the gallbladder fundus. And then as I keep going down, there are some findings that start coming up. And I'm going to show you the coronal as well. Sorry, it's really zoomed in. I'm going to fix that in a minute.
It looks fine.
Yeah.
Oh, good.
Okay, here we go. So any takers for the findings on the CT that I'm trying to show? Feel free to unmute yourself and say something.
I always say stuff. I see small bowel wall edema, as well as it's pretty extensive. It looks like it's involving jejunum and also mesenteric edema. So I'm going down my differential of small bowel edema, such as enteritis. Oh, wait, is it? Wait, show me the terminal ileum. Oh yeah, and it's also involving the ascending colon.
Yeah.
Oh, I guess it was that loop was the ileum. So it's involving a lot of the ileum. So I'm thinking about enteritis, hypovoluemia, some kind of vasculitis, ischemia, but that's like a weird distribution.
Yes, indeed. Something else that we always think of when people have long segment small bowel wall thickening, ACE inhibitor therapy, if she's on ACE inhibitors.
Oh, ACE inhibitor. Yeah. And it looks too extensive without strictures to be inflammatory bowel disease, but
perfect. Yeah. Excellent. Yeah. So all these differentials are very good and valid when patients present with, diarrhea and infectious inflammatory kind of clinical picture. But the part of the history that I withheld, and that's why I'm showing this case here, is this patient has SLE, systemic lupus erythematosus, and she currently, during the CT, has active manifestations elsewhere in the form of cerebritis, etc., of SLE. And this is an unusual manifestation of SLE. So these patients can present with small bowel or bowel wall vasculitis, basically, which can manifest in the form of waxing and waning pseudo-obstruction. I found a couple articles and case reports and case series that talk about intestinal pseudo-obstruction in patients with SLE. One paper also talks about this manifestation and calls it visceral pseudo-obstruction. And some case reports describe how these have been misinterpreted as small bowel obstructions. Patients have gone to the OR and they haven't really found any etiology for this. So in our patient as well, they had waxing and waning bowel obstruction. It is said that this manifestation of SLE responds to steroids. These patients get steroids for other entities as well. And then they tend to, in her earlier presentation, they had small volume ascites, but subsequently they started getting larger and larger volumes of ascites. They also had...
I knew, that's massive.
Yeah, exactly. That's massive. And I'll tell you reasons for why these patients can get ascites. But they also had a CT angiogram done, and none of the medium vessels were involved. They were all normal. So this was a few years later. They have hydronephrosis on both sides and they have nephritis, and they have massive ascites, which is very poorly controlled, as you can see. So, I found this older article, but really very well written, of different manifestations of SLE, and I'm going to show you that in a minute. So can you see my article?
Yes.
Okay, excellent. So this is a 2009 article published in the Canadian Radiology Journal. And they talk of all these manifestations of SLE, which, I hadn't seen. These are uncommon, of course, but they talk about ascites seen in up to 10% of patients with SLE. And there are different etiologies why these patients might develop progressive or ascites that may not respond to conventional therapy. And different reasons include serositis or pancreatitis, nephrotic syndrome, because they can go into renal failure secondary to nephritis. And also one interesting entity is these patients can develop peritoneal inflammation secondary to vasculitis. Chylous ascites is another manifestation. It's rare, but in addition to ascites, there are so many manifestations that as a radiologist we can come across. GI involvement, not only in terms of mucosal ulcers, which we can't diagnose on imaging, but also they talk about this entity, which is small bowel, particularly involving the small bowel. And I'll show you some pictures in this article. If you look at this picture here, it very much resembles our patient where they have dilation of particularly the jejunum and concentric bowel wall thickening of the jejunum. Then they show us some more pictures of colonic involvement. And they talk about urinary tract involvement with proteinuria and other manifestations as well, including pancreas, adrenals, liver. The liver can be involved in the form of chronic active hepatitis. And then one feature that one of my favorite attendings always talks to us about is these calcified granulomas in the spleen. They can develop progressive decrease in size of the spleen, shrunken spleen with calcific densities within it, related to lupus. So this image here, they talk about how these patients did not have any granulomatous infection to explain the calcification, but splenic calcifications are known to be associated with SLE as well. So that is my SLE dose for you. I'm going to stop sharing.
Wow, very cool. I feel like I see a lot of pericardial effusions and maybe ascites, but I have not seen that bowel wall edema like that.
All right.
Awesome. Okay.
Yeah, so this was a patient. The patient was pregnant and they had concern for like a fibroid of the uterus, and these are some of the selected images: axial and coronal haste, axial in and out of phase images right here, and axial T2 fat SAT images. So of course, means you see this big lesion over here. I'm just scrolling through.
Huge dermoid. Is that it's satting out? No.
Yes, actually, yes, that's right. What we were really kind of not sure is that what is this whole structure, because it is like a
tube.
Yes, exactly. It looks like a tube. So what are these small things which are within this tube? So we kind of thought a lot, kind of consulted among ourselves, and finally I said that the only way I can explain this is if the dermoid actually ruptured and it kind of filled in within the tube or something like that, and somehow it got contained within the tube and just was growing.
Is there any torsion? I'm like trying to find the pedicle there, but I don't see any like whirl or twisting or anything. When you see a dermoid this big, and especially if you're worried about rupture, you want to make sure there's no torsion.
Right. We didn't really see any.
Yeah, I don't see anything either that would suggest.
Yeah.
There is the possibility that the dermoid is just in the tube.
Yes, there is a possibility, but it was just like so like these small elements generally we see contained within the dermoid, and they look like they are just freely floating within this. So that's what I was thinking, that maybe it has ruptured, but certainly I was not sure about it. And there was looks like there was another dermoid in the making in the other side as well. Looks pretty similar, satting out here. There's a fat fluid level over there. So so this patient did underwent surgery, robotic surgery, and they did confirm that this was a dermoid, and it had actually ruptured. So looks like.
Wow. So when you say ruptured, like, is it a dermoid of the fallopian tube that ruptured in the fallopian tube, or an ovarian dermoid
Ovarian
that ruptured
dermoid
in the
which
fallopian tube,
ruptured.
or you can't tell?
Well, based on their path note, it looked like this. They meant that it was an ovarian dermoid which was ruptured into the tube.
Got it.
Yeah.
I did find some case reports online that you can have dermoids in your fallopian tube.
Okay. So,
wow, that's crazy.
yeah, the path report clearly said ovarian dermoid with the rupture. So that's
Wow.
why.
And then another question. So when did they do the surgery? Like, did they do it during this pregnancy or after?
Yeah, they did it during this. They did a robotic surgery, kind of took it out.
Nice.
Yep.
Yeah. So you can do it probably best is second trimester, before the fetus gets too big and after the organogenesis. So you can still use anesthesia.
Right.
Very cool. Can you just, for the residents, show again, like the fat satting, that kind of, because I saw it on both the fat sat and then also I think the in and outs, right?
Yes. So right here, you can see that. So you can see that this area, which is bright, and that's kind of satting out over here. And there was certainly like other lobules also, which had the same signal intensity. And
but all of
thing,
that fluid is also setting out.
Whole thing is setting out.
Yeah.
So they found bone, cartilage, hair, and everything in this.
Wow.
Yeah.
Very cool.
Yep.
Okay. And you had one more?
Yes. All right. So this was again another pregnant patient, history of abdominal pain, rule out appendicitis, and these are some of the selected images, coronal, sagittal, axial images through the lower abdomen and pelvis.
Yeah, his cervix is not normal.
Okay, what is not normal?
It looks incompetent. It looks like the amnion is like kind of protruding into it.
Right. Very good. I think that's the key finding. So of course, when we looked at it, the cervix, the appendix was normal. We really didn't see an appendix. I think we did find it somewhere, and we were able to convince ourselves that it's normal. So there's no appendicitis. Patient did have a history of some vaginal bleeding. They did an ultrasound in the ED. They didn't find anything. But when you look at this MR, clearly this lower uterine segment does not look very normal to me. And initially we thought that this might be a contraction or something, but it was persistent. And also, if you look at the overall length of the cervix, it was kind of effaced. And you could see that this whole part was kind of ballooned out. And unfortunately, the patient was discharged. And the returned back to the ED with an abortion. Basically, patient aborted at home. So I just wanted to kind of show this case to kind of highlight that sometimes we can look at this cervix. Sometimes you may think that this contraction, but we have to pay close attention to the overall length of the cervix and see if how much of that has effaced. Because if there's a point where there's vaginal bleeding and there is already effacement of cervix which has started, then that is kind of compatible with abortion in progress. And we did call it, means it was like a kind of a call case where the resident was only focused on the appendix and they just kind of said no appendicitis, but they didn't call it. But later on, when I looked at it, we thought that there is a case for abortion in progress, but unfortunately that was too late.
Yeah, I'm thinking with the bleeding, it might have already been kind of in progress rather than just like cervical incompetence. But yeah, this is really early to have like so much cervical incompetence.
Yes.
And if it's less than 2 centimeters like this, they usually put the patient in Trendelenburg. They're on bed rest. They might do a cerclage. This is pretty early. So, it would have been like the patient would be on bed rest for several months,
Right.
But yeah, it's a good
Yeah.
case. I have a question about their myometrium, because under the placenta, it looks like in the bottom left corner, it looks almost is that a fibroid or a contraction? See how like that
This
myometrium? Yeah.
I think there's probably a small fiber, let's say. I'm not sure about it though.
So I've been faked out before with like a contraction where then on a
it
later
could be.
image, it goes away. So that's just one tip for MRI, because we get so many sequences and we get like multiple points in time. That's one way to distinguish a contraction from a fibroid.
Yes.
Do you have any, like, can you show a later point in time?
Let me see if I can pull up 1 second. I just have, let me pull up this, but that's a diffusion. Let's see. I have a T1, which is
Still looks kind of thick.
still the same. Yeah.
Okay.
Yeah.
Cool.
Yep. Yeah. So my understanding about abortion in progress is that that all the intervention you have to do is you have to prevent this effacement, especially in kind of a high risk pregnancy, and you the earlier the better. Kind of if it's already kind of 50% effaced or something like that, then there's hardly anything that can be done to prevent that. It'll eventually it will abort. So yeah, means we should have. Unfortunately, there was no such history on this patient, like this patient was high risk or anything like that, and that was not in the radar for this patient.
Aarti, this is Rupa. I just wanted to add one more thing. We had a lot of discussion with the OB people and one of our residents who's previously OB trained also. And I was confused between when to call something as cervical incompetence versus which is like an impending preterm labor, if you will. So one thing she said was cervical incompetence is usually painless, and they'll usually have a history of multiple mid-second trimester abortions. But our patient was G4P3 and had no such history. And in her case, her contractions were painful and associated with vaginal bleeding. And one other good point she brought up was usually in primi, what happens is the head engages and that's why the cervix gets effaced. But then with more and more parity, there is more laxity in the cervix that the head doesn't have to necessarily come all the way down as the presenting part to efface the cervix. So these multiparous women can go into labor without much cervical effacement or like presenting part showing up at the introitus. So she said technically this was sort of a preterm labor more than a cervical incompetence.
Yeah. Excellent. That's what I was thinking was like the difference was the vaginal bleeding, but also if she's having contractions, that's different.
Right. Painful versus painless.
Great points.
It was a hard case and it reminded us of your amnion, the meconium case from last week with the distress. Yeah.
Okay. So this was a penile MRI. And I want you to tell me if you see any findings. The patient basically had pain during intercourse. So this is the T2. And then I'm going to show you the post-contrast in a minute. This is a important image. Oh, there's an arrow. So what do you guys see and what do you think this is?
Yeah, we're unmuted. Okay, so looking at this on the patient's right side, I don't know if you can't see what I'm pointing at. There's this
Yeah.
Defect, sort of lateral transverse kind of wedge shaped going through the actual soft tissue of the penis with this supposed hematoma or fluid collection just lateral to that. So, all things considered, the concern for a penile rupture or a broken
fracture.
Like fractured penis.
Yeah, exactly. So this is a penile fracture. I've had friends who are not in medicine be like, what, fracture? Like, is it possible? Is there a bone? So a couple of things about penile fracture, like it's, there's no bone in the penile shaft, but it's basically a break in the lining along the corpora, which is the tunica albuginea. It's usually when there is trauma. So for example, if during intercourse, there's like a trauma of the penis, like the erect penis hitting the pelvic bone of their partner. And then like it gets bent, and then this corpora, the capsule, the thin capsule along the corpora ruptures, and then there's extravasated hematoma. So this was actually just a nice example. Not all penile fractures need an MRI. Some are diagnosed clinically. Many are diagnosed with ultrasound. What you want to do on ultrasound is get this like sort of view of the penis where you see the two corpora and the spongiosum, like the two eyes and the nose, and then you look for any disruption in the tunica overlying it, and then tell them, you know, where it is, what the length is, and how big the hematoma is. They want to usually repair this within 24 hours. And what they do is evacuate the hematoma, and then they try to sew up the tunica albuginea. You want it really airtight or water seal tight, because if there's any leak, then it's going to prevent this the penis from recovering and being able to have like a full erection in the future. So just an example of a penile fracture. Great job, Trinity residents. I'm going to stop sharing for a sec. Okay, so this was an older patient who showed up with right upper quadrant pain. And I want you guys to focus on the gallbladder and tell me what you think. And I'm going to show you the coronal as well. So I'm just going to scroll through slowly here so you can develop an impression. And then this was the coronal.
Yeah, sure. So we have a coronal CT with contrast here that's in the arterial phase, and we see that the gallbladder is distended. The wall is enhancing, but it's kind of irregular. There's nodularity to it. And at the inferior portion of the gallbladder near the fundus, you can see that there's portions of the wall that look like it's appearing to slough off, or like the adherence isn't there anymore, or like discontinuity within the wall. So all things considered, this is suspicious for like a necrotizing gallbladder or
Yeah, good. So this wasn't called initially. So I want to, great job. So this is actually just a fold in the gallbladder. That's not the finding, but we can see, like, you should basically be able to see, if you see mucosal enhancement, you should be able to follow it all the way around. And you can see it here, and you can see that here you're losing it, right? And it gets like all irregular. And there might be even fluid, like a little fluid collection outside of the gallbladder. And then on the coronal, like we were saying, it gets, it looks all irregular here. Maybe there's even, maybe here you even see like this frank communication between the gallbladder lumen and like this extraluminal fluid. So anyway, that wasn't called because I think partially because they hadn't looked at the coronal, they just kind of looked at the axial, maybe easy to miss, etc. I'm going to show an ultrasound now, so I'm going to pull it up before I accidentally show you the. Okay, so this is the ultrasound. So what do you guys think here? I'm going to keep, okay, this is the region of the gallbladder.
Yeah, yes. So looks like, yeah, we got some pelmet healing within at least the wall of the gallbladder. It's just that there's pneumatosis going on.
Okay, good. So you called it comatailing. I would call this, echogenic stuff with dirty shadowing, concerning for emphysematous cholecystitis, like you said, pneumatosis or air in the gallbladder. So this is a nice example of dirty shadowing, not the, clean shadowing you would see if there's calcification. So then like if you see that, have a low threshold. If you're either you can just call it if you feel really confident, or, you know, there's other possibilities of being able to see kind of air in the gallbladder, like if they had a sphincterotomy and the gallbladder was filled with air. So sometimes people question, like, is it actually in the lumen or is it in the wall itself? We saw from that prior CT that there was no air in there, so it was pretty suspicious. But anyway, we ended up getting a CT. Oh wait, this is the, so we ended up getting a CT, and now you can see that there's emphysematous cholecystitis, and then that extraluminal part where there was a rupture even has air in it. So both of these are similar. Gangrenous and emphysematous cholecystitis are both seen in poorly controlled diabetics. They're kind of on a spectrum. The nerves are often denervated at this point, so they might not even have pain. They're high risk, high morbidity. Here we can see it's like following in the wall here. So emphysematous cholecystitis. Awesome. Okay. Hi, Steve.
Hello.
Welcome back. I have a few more cases I'm showing, and I'm the Trinity residents from Florida are taking them. Hold on one second. I'm going to pull up my next case. Okay. Okay. So the focus is on the right kidney. You can see that there is a sort of ill-defined process here. On the pre-contrast, it looks like this. Arterial, it was actually a coronal, it looked like this. And more delayed, it looked like this. So what do you guys think about this lesion or process? What would you call this?
So large mass in that kidney didn't seem to drop out on the initial fat sats, but it is enhancing kind of peripherally and internally. I mean, RCC would be, I guess, on our list.
Okay, good. Good. One thing is just to not call it like a phlegmon or pylo, which is kind of what it was initially called. Like they thought it was sort of an ill-defined process, like could be pylo or phlegmon. I guess there's always a possibility it could be a phlegmon, but this looks more like a ill-defined enhancing mass. Now the question is it an RCC or is it a urothelial? Which one would you favor?
It's not like
Is
solid.
the,
Does it go down the actual?
Pelvis enhanced, I think.
So I would try to point out here, like the calyx is sort of here and enhancing and then kind of cupping this thing, right?
That makes it more like the urothelial, if that's getting that far down. I do.
Yeah, so that's one thing that for me would suggest it's more urothelial. The other thing is that they call it a ball or a bean. So RCCs tend to arise in the cortex and grow like a circle, like a ball. So they can be endophytic or exophytic, but they usually are a fairly well-defined ball, and they grow like a ball. Whereas an urothelial tends to sort of maintain the renal contour and grow, like maintain the bean shape of the kidney. So anyway, this one looks a little bit more like it's maintaining the shape, it's infiltrating into the parenchyma, but it's not a well-defined rounded mass that arose in the cortex. So anyway, this was biopsied actually through ureteroscopy and was a urothelial cancer. So a couple of points about that. So we think about the ball versus bean. We try to see if it's communicating with the collecting system. Obviously, we want to look for any Mets. But then if you ever even think of the possibility of urothelial, you should always bring it up because it's a different management. They will do a nephroureterectomy where they resect the entire ureter as far as they can dissect. Sometimes they can't get the very distal ureter down in the pelvis because it's a really tricky area to get all the way to, but they try to get it all the way down because the whole system is at risk. And then obviously this is a field defect, so you'll want to keep surveilling the patient. Patients who have an upper tract urothelial cancer have a much higher risk of eventually developing a bladder urothelial. It's not the same other way around. So if you have a bladder cancer, you don't have as high of a risk of developing an upper tract. I don't know why that is. Maybe it's the tumor cells have been like shedding down the urothelium and down the ureter the whole time. But just be very careful on the surveillance scans to look for the distal ureter that might be a remnant as well as the bladder. So this was just a urothelial cancer. Okay, This is another case. We've got splenic lesions. So residents, I want you guys to tell me what you see. So this is the T, I'll show you a few sequences. This is the T2. T2 with fat set. I'll pull the in and out next to each other. So this is the out of phase and this is the in phase. There's something pertinent about the lesions on these in and out of phase. And then
They're dropping out on the in phase, right?
yes, they were dropping out on the in phase. And then I'll just show you,
Hemochromatosis.
this is the pre-contrast. So they're a little bit dark. And then this is the venous. And I'll tell you, they just kind of had some progressive enhancement. So what do you guys think? You said they were dropping on the in phase. I'll bring that back up just to.
Right, like some sort of like conjugal window or some bunch of hemangiomas or something in the spleen.
So first of all, they're dropping on the in phase. So what does that mean? So this is the in phase. This is the out of phase. They're getting darker on the in phase. That means they have what in them?
Hemochromatosis or iron.
Yeah. So either iron, metal, or air, something that causes susceptibility. But in a splenic lesion, you're not going to have metal or air. So these all have iron or hemosiderin in them, but not really like the hemosiderin deposits of gamma antibodies in portal hypertension. So there are multiple lesions in the spleen. They're T2 hypointense. They have hemosiderin in them, and they have progressive enhancement. Do you know what this entity is?
Other than hemangioma, I wasn't sure if you'd know this one.
I'm hearing several different voices, and one said hemangioma. Hemangiomas usually are T2 bright, and usually either have pretty robust enhancement or nodular enhancement. They're not usually T2 dark like this. I'm going to ask the attendings if you guys want to call a friend.
Yeah, sure. You'll have to call a friend on that one.
Okay, attendings.
Aarti, we were thinking teleosis
No.
or large, some kind of weird granulomatous inflammation.
No.
What else?
I don't
was
have path proof on this, but this fits the classic kind of radiology description. Anyone? So I think this is littoral cell angioma.
Aren't they supposed to be like T2 bright?
Yeah.
No,
I was thinking of that, but then the T2 signal kind of swayed me away.
I think they're supposed to be T2 dark and have hemosiderin in them. And I'm going to show you my Radiopedia article that says that. Not that that's full truth, but it is the crowdsource.
Classic splenic lesion. Nobody agrees.
Okay, here's my radio. Do you guys see the Radiopedia?
Mm-hmm.
Okay, littoral cell angioma. Oh wait, where's imaging? Okay, T1 low in T1 and T2 signal due to hemosiderin, multiple masses. So not high. I think they're low. At least according to me and Radiopedia.
I don't think they're always T2 low or like.
Okay, I want you to bring up a counterpoint because, and then we can talk to these people about editing their. the ones that I've seen have been T2 low, but I'm going to tell you a few more points while you're looking it up, Maria.
Yep.
I'm going to bring up a few teaching points about littoral cell angioma.
Okay.
So one, well, let me just get this out of my way. One, they tend to be multifocal lesions. They usually are benign, although rarely they can develop into littoral cell angiosarcoma. They are actually thought to be on like some kind of, nobody knows why they develop, but it's thought to be on an immune spectrum. So some of the patients have Crohn's disease. My patient actually had several autoimmune disorders, including Hashimoto's thyroiditis. So I don't know if that was related. and you don't need to really do anything about them. They are a primary vascular tumor arising from the cells lining the red pulp, which is why they're called littoral cells, and they have a dual endothelial and histiocytic differentiation. So that's how on path they can tell what they are. Did you find anything else about their imaging?
Not really. I think they're a little bright on the fat sat T2s, but on the haste, they're like, it says T1 and T2 dark. I pulled up a few papers. There's an AGR, it's an old paper, and they are basically have a CT case, but yeah, I think you're right. T1 and T2 hypointense.
Okay, that is my thing about littoral cell angioma.
Yeah.
Okay, I'm going to stop sharing. So Steve was just saying that, he brought up some cases online that some looked bright, some looked dark. So I guess it could be variable, but we were saying that in general, things that are darker tend to be benign in the spleen, in the ovaries. So like more fibrous things, fibromas, leiomyomas. And then in the spleen, multifocal T2 dark, you can think about this littoral cell angioma, but if it's a solid mass that is T2 dark and has kind of a spoke wheel appearance, then we think about a Sant tumor, which is a sclerosing adenomatoid nodular transformation. So generally, I feel better when I see kind of dark things in the spleen. Okay,